Today about new frontiers in functional neurosurgery. Now the stuff that I'm going to be talking to you about is all experimental. None of it is approved by the FDA, but we're working on it. And the reason I'm talking to you about it is because as a functional neurosurgeon, what I love to do is deep brain stimulation. Well, why? Because it makes people better. It improves their life. Right now, our indications are for Parkinson's disease and essential tremor. However, I'm going to show you throughout the course of this talk where we can go with DBS. And this is just scratching the surface. There were probably 6 or 7 other experimental indications that I didn't even cover in this talk. I have nothing to disclose. And the objectives today are going to really talk about the new targets for deep brain stimulation, and these are a list of the ones that I'm going to hit in no particular order. This is a list of all of the targets right now that are currently being looked at experimentally. It's kind of small type because there's quite a lot of them. And the and some of them, the middle column, you'll notice this middle column is actually where in the brain we're targeting. This is the actual disease process. This is where the brain we're targeting, and for many of them we're targeting several areas, so that the research is going strong and heavy. And this is actually a diagram of where in the brain we might be targeting. Some of the normal targets for deep brain stimulation are the globus pallidus. The globus pallidus internus, I guess this isn't working anymore. So anyhow, VC and VS. We also go to the subthalamic nucleus. There we go. Came back. But some of the interesting ones we're going to talk about today, really interesting, are nucleus accumbens, and we'll talk about why, and this VCDs area, because nucleus accumbens is the reward center for the brain, so it's the obesity, the addiction topics or target. And VCDs is the depression target, and those are huge, huge indications. This first one is a tiny little indication or disease process. It's neurodegeneration with brain iron accumulation. It's a very small group of patients, but it was a pretty impressive study. In this case, Timmerman did a multi-center retrospective to bilateral palladial targets in 23 patients, and if you look, this white part of the graph really shows how they improve, both the severity of their dystonia, the disability from their dystonia, and their quality of life. And so greater than 20% improvement, which for 20% improvement for somebody who is completely debilitated and not able to get up and out of bed or participate in their life is huge. Doesn't sound like a lot to us, but if you could move around more and get around for 20% extra time during your day, how would that change your life? So if you can't move at all, 20% is a big deal. And if you look at people who were slightly less than 20%, that's the gray portion of the pie, we're looking at a significant portion of those patients. Now these are all small trials because again, there aren't a lot of folks who have this disease. And this is essentially just more graphs showing that their lives did get better. Both their symptomatology, this one is interesting because it's the overall quality of life, percent increase, and that's huge. Another one is Meigs syndrome. Meigs is idiopathic cervical dystonia associated with blepharospasm, cervical dystonia, facial and oromandibular dystonias. And this was, they did thalamic PET, and that's how they figured out. So one goes, well, how do you know where in the brain to stick this tiny little lead and start stimulating to know if it's going to work? So sometimes we do it based upon animal models. In this case, they did it based upon a PET study, and they found that in the thalamus and the basal ganglia, there were lesions on PET. So this looked like this might be a good target for them. And this was in 2010. At 12 months follow-up, there were only 3 patients, but they did get long-term relief in their rating scores, and it indicates the GPI, which is where they were targeting, is a likely target for these folks. So we start out really small with these patients, and we do 2 or 3 of them after some animal models, and then we go to larger studies. But at least it gives us an idea that this is possible and that this is something that we could make better. Next one is cluster headache. Now I'm going to give you a little bit of a, so cluster headache has been looked at. Their target is the posterior hypothalamus. And so again, based upon imaging studies that show in a cluster headache, which is right here, there's some increase. And so what they looked at was stimulating, this is an Italian study, they stimulated and it showed both activation and deactivation. So this actually suggests a functional change in modulation rather than just inhibiting in an area that's working. That's pretty interesting to us because what we think about when we think about electrical stimulation in the brain is that we're just turning something on or turning something off, either inhibiting a disinhibitor or inhibiting something with the electrical stimulation. But this study actually showed us, because this is post-stim, it actually showed that we can functionally modulate the pathways in the brain. So it's less important how we can treat cluster headache with DBS. It's more important to prove to us that we have the capability of functionally modulating the brain as opposed to simply just turning off or on pathways the brain response. I will tell you that the posterior hypothalamic target is a dangerous target. There are a lot of blood vessels here, and so they had several deaths, 2 or 3 deaths, just from the implantation. So I'm not saying that this is a target that we're going to use quite a lot, but these are also patients who were treatment refractory and ready to commit suicide to begin with, because that's one of the criteria for cluster headache, or not criteria, but one of the qualities of cluster headache is this is so bad, people are just ready to kill themselves anyhow. So I'm not saying it's justified, I'm just saying that it happens. This one is very interesting. Gyrus Tourettes syndrome. So these are the people who have tics. They either have physical tics or they have vocal tics. The most common of which are not the most common tic, but the most well-renowned, or they have corporalia, so they curse just out of the blue and for no reason. It is associated with obsessive-compulsive symptoms, and so we do have a target for obsessive-compulsive symptoms, and so that's why we think this works. But this is interesting because there are several targets that they're looking at in the brain. The centromedian and ventral oralis internuclei of the thalamus, they got moderate results with. They looked at nucleus accumbens, which I'm going to talk about for reward center, and they also looked at GPI, but this one was particularly interesting, this study, and the reason I highlighted it was because they put leads in a couple of places in the brain, and then they tried them both to find out which one worked better. And what they found was that Globus pallidus internus was the best, and they had significant improvement in not only their tics, whether it be physical or vocal, but also their associated OCD type symptoms. So it did work both of those pathways. It's interesting as well because it gave psychiatric researchers verification of what they thought, which was that it was the same pathway that was being activated, and essentially verified that Gilles de Tourette is a form of an obsessive-compulsive disorder, and the tics are likely compulsions as opposed to some other type of organic process. So the thing I think that's exciting about the research is letting us know some things about the disease processes themselves while we're learning about how it can make people better. Aggressive behavior. Now this one's interesting. There is this particular study down here at the bottom. This was in a patient who had self-mutilating behaviors. A 22-year-old female. She was implanted bilaterally to the hypothalamus. Again, that very dangerous target because of all the blood vessels that are there. But it did significantly resolve some of her self-mutilating behaviors. And they've also looked at it in another 6 patients. Posterior medial hypothalamus, 5 had significant improvement. I want to bring something up because the ethicist in me just can't stop. These are all patients who have aggressive behavior, or in this case, it was a patient who was self-mutilating, so clearly she didn't have capacity to make decisions for herself. And she had a very, very dangerous target that they were looking at. Now she had success, and she didn't have any side effects, but what are the ethical, is it ethical to subject patients who don't have any kind of capacity to experimental procedures? We're just sticking something somewhere. And I'm not going to give you the answers. I just want to raise these questions as we're thinking about things because this is the forefront of neuroethics. There's an entire conference next week at the Cleveland Clinic all about that, all about the questions associated with this. And then if it is okay, if we do think that it's okay to subject people who do not have capacity to experimental procedures or to surgical procedures that have risk, what are those implications, let's say, in aggressive behavior for prisoners? A very vulnerable population, a very aggressive population. How do we balance the good of society against the risk of the vulnerable populations, and how do we protect that? I just want to get you thinking about that, because that's going to be a big deal coming in the future. Obesity and addiction, these are big ones. Now, it's a pretty horrible picture to show, especially at 7:30 in the morning, but this is how we figure this out. This is how there were the obesity target and the addiction target, both are the same, the nucleus accumbens, were based upon rat models of addiction, both alcohol addiction and rats that were bred to just have no satiety centers, so they would just eat and eat and eat and eat and eat until they die. Rats that were bred to have alcohol addictions, and they stimulated them in the nucleus accumbens, the reward center for the brain, and they found that, in fact, they were able to get them to eat less, and they were able to get them to drink less. You think about alcoholic rats, and this is the pathway, and it's a lot to look at, but the nucleus accumbens is in the center, and what essentially happens is this is the normal pathway. This is when everything is in alignment. But when you think about addiction, whether and these are chemical addictions, so I'm not talking about obesity right now. When you think about addiction, what happens is the reward for the addiction, the taking of the cocaine, the drinking of the alcohol, overrides and disinhibits this normal reward response. So we think about it essentially like a kid who listens to a really, really, really loud music all the time. And then he or she walks into a room and people are talking normally and have a hard time hearing. And that's because normal to them is that really loud music. And you can think the alcohol or the other chemical substance that essentially releases neurotransmitters in the brain as that really, really loud music. So when you take it back down to a normal level, they don't hear it. And so what happens is we turn on this nucleus accumbens, and without ingesting the alcohol, you override that pathway, and so they think they're hearing really loud music, or it seems the reward centers of the brain seem as if they're getting the alcohol. They don't have the cognitive effects, they don't have the other effects of the alcohol or the systemic effects, and yet their brain is essentially confused into thinking otherwise. Kind of interesting. And this is the target in the brain. So that's exactly where we would stick the electrode, right near these optic radiations there. And it's been very effective in alcohol. It's been less effective in obesity, so there's still some work to be done on that. But certainly that indication is there. OCD is one that we actually have a humanitarian device exemption for in neurosurgery right now. And it's based, the target is the VCVS target I showed you before, and I'll show you again. But Greenberg, who's a psychiatrist and whose father is a very famous neurosurgeon, wrote the sort of the handbook that all neurosurgery residents have. They came up with this VCVS target, and they've shown that there, in 36 patients at least, that there's some sustained improvement in the Yale-Brown Obsessive Compulsive Scale in medically refractory patients with OCD. And there's currently a multi-center trial. However, we can, under this HDE, implant right now for OCD. Ethics questions. Do psychiatric patients possess the capacity to participate in informed consent? I would argue that patients who have their lives as debilitated as those who have OCD but have the capacity to realize, and OCD patients do, that there is a problem and that it's affecting their life, most certainly have the capacity to make that decision, but it's a question that we ask. And what additional protective measures do we deem critical in the protection of these vulnerable subjects? Kind of going back to that protection of vulnerable subjects when we're talking about prisoners who may have aggressive behavior if we have a target such as this. And this is the actual target. So it runs right in between the caudate and the putamen. There's the globus pallidus. So this is VS. So most of the lead is in VC and some of it is in VS. It's a really interesting target. I've actually been in on some of these cases, and it's fascinating to watch because you can literally modulate emotion. Literally turn on the stimulation in a certain configuration, and the patient's whole demeanor changes. and they say, yep, I like it right there. And then you change it a little bit, and their voice changes, their face changes, they flush a bit, and they say, yeah, no, turn this off, this is horrible, stop it. So it's fascinating to look at, and it's something we need to think about from an ethical standpoint, because of course psychosurgery has had an unfortunate past. And so we need to step beyond the unfortunate past of frontal lobectomies that were performed willy-nilly and ad nauseum and inappropriately back in the 30s and the 40s in Philadelphia, where I trained, and step beyond to ethical treatment of psychiatric disorders in a way such that we don't create stigma and we do improve lives. These are the current ongoing OCD targets, studies, and they've all had at least a 35% improvement in the Yale-Brown scale, which is what is deemed significant and sustained improvement in quality of life. So now let's get to depression. I'm going to give you some small trials on depression. There was a very large trial that actually failed. It unfortunately failed, I personally think, because the design study was poor. And I have actually seen these depression patients, and we are afraid. We were afraid to let their generator die. If we let their generator die, they would become suicidal. I have seen patients with the depression trial personally I saw a guy who hadn't worked in 15 years, got his DBS for his depression, and we called him back because they're high energy. These generators are high energy, so they end up depleting about every 12 to 18 months. We called him, we said, your generator's going to deplete. We need you to come in to have surgery, because we're worried, of course, that he's going to relapse. And he's like, I can't get time off of work. I'm like, well, you better take the time off of work or you're not going to want to work. But anyhow, I've personally seen these patients do well, and so that's why I think that depression is a target that's coming. The large multi-center trial just needs to be redesigned. But these are a couple of them, and essentially they did a single blind sham of 4 weeks, active stim for 24 weeks, and another single blind DC phase, and they had to stop that after 3 patients because they found it unethical to just DC the stimulation. So that tells you a lot about how much it works. They found it unethical to stop the stimulation, so they changed their study, their design trial, such that they no longer stop the stimulation. And there was a significant decrease in depression and an increase in function, and it was associated with chronic stimulation. There was some remission response seen, but it's interesting because they had an increase, and then they had a little worsening of their depression, and then they had an improvement again. So overall, they were about 64.3% improved. No patient that had remission of their depression had a spontaneous relapse, as long as the generator was working, so that's important. And it was similar for major depression and for bipolar. And nobody had manic or hypomanic episodes, which people were concerned about, so it is effective probably for both bipolar and major depressive disorder. That's a huge portion of our population, a huge portion of our population. Now, surgery isn't without risk, but at the same time, the medications for depression and bipolar are incredibly toxic and have so many different side effects. So we certainly are looking at the possibility of providing patients the ability to get off of their medications and live a depression-free life while taking a small risk for surgery. That's pretty exciting in my book. And here's where it's targeted. It's the superior cingulate gyrus, and that's exactly where the lead goes. There's 3 contacts on a lead, so 0, 1, 2, 3, so 4 contacts, sorry, 0, 1, 2, 3, and it sits in the superior cingulate gyrus, which is what we think. That's one of the targets. The other one was VCDs that I talked about. This is a multi-center study that was just recently published again. Dr. Lozano out of Toronto is a forefront and a leader in deep brain stimulation, and he published in neurosurgery just in 2012, 21 patients with bilateral SCG, and they had excellent improvement. This is improvement, percent improvement at 1 month, 6 months, and 12 months. Greater than a 60% improvement in the Hamilton Depression Rating Scale. So definitely an improved quality of life. This is how they change from baseline, meaning this is the higher you are on this scale, the more depressed you are. So certainly there's a very clear decrease, and it's sustained. You can see it's almost, there's tiny little ups and downs, that's the whole group, but it's sustained for the entire period of study, which was 12 months. And then this is the percent of subjects. Clearly, many more subjects, these are the responders, these are the remitters or non-responders. So clearly, and particularly out at 7 months, we have almost 70% response rates. So many more responders than non-responders. And this is actually showing how the brain blood flow and the water movement changes. And so this is at 3 months of stimulation, and particularly look at the frontal cortex. There's a significant increase in blood flow in these areas and in water flow on the O-water PET. So it does actually functionally modulate the brain. Another study, Kennedy, this was a 3 to 6 year follow-up. So now we've said at 12 months we do think that depression works, although we haven't convinced the FDA quite yet, so we can start putting things in. But this is 3 to 6 year follow-up. And there was implantation, there was 62.5, then it dropped down to about 46%, and then it increased. So there was a 75% response rate at 3 to 6 years for these patients in this study. And they actually had improvements, sustained improvements of physical health, social functioning, and it progressively improved. So the longer they were stimulated, the better they did. Now, we should note that there were 2 folks who did commit suicide when they had relapses, but again, not to be crass, but this is a group of people who were treatment refractory and suicidal to begin with. So we would expect in just the general population in a control group to have had a number of suicides. So I would not attribute those suicides to the deep brain stimulation or to the anything to do with the stimulation and everything to do with their disease process. Alzheimer's is another really interesting one. There's a couple of things that they've done in Alzheimer's. In 2012, they just did a study. These are, you have to think carefully about Alzheimer's disease because these folks were, first of all, mild, probable Alzheimer's disease, right? And it's an open label trial, so it's not really going to be class 1 evidence, but it was an open label trial, bilateral fornicele DBS, and what they looked at was actually glucose metabolism because they wanted to prove that we could improve the functionality of a brain that's failing. And so what they were able to show was there was increased metabolism in 2 different orthogonal networks, the frontal temporal parietal striatal thalamic network, boy that's a mouthful, but that's essentially the pathway, and a frontotemporal parietal occipital hippocampal network. That's the one that's interesting because the hippocampus is essentially where memories are held and made, and Alzheimer's disease is essentially a dysfunction of memory, or not essentially, but a portion of it is a dysfunction of memory. And so that's why this study was particularly interesting, and they had increased connectivity even after a year of DBS, as opposed to the control patients who have decreased connectivity in these areas on PET study. And this is the pathway they're looking at. It's very complicated, we're just gonna fly right past that. But the other interesting one was, in Canada they have an epilepsy target that was just approved for implantation, and they're using it. But that epilepsy target, it has not been approved here, but the interesting thing about the epilepsy target, and the reason it's interesting for Alzheimer's patients or for memory dysfunction in general, is they took and they implanted in the entorhinal cortex, which is right here, it's right near the hippocampus, and the amygdala, which is essentially how memories are made, in an attempt to stop seizures. But in an attempt to stop seizures, one of the side things they said is, well, let's take some of these folks and let's see how they do on memory tests. And they'll play video games that were memory tests. And what they found was with a small amount of stimulation, and of course patients can't feel this, so it's totally painless, they found that there was significant improvement. This was done at UCLA just recently, published on, what is it, February 9th of 2012, New England Journal of Medicine. They were able to improve the motor response times. They were also able to improve the memory recall on these patients. So that's interesting, because these patients didn't have memory dysfunction to start with, although one could argue that somebody with epilepsy does sometimes have baseline memory difficulties because of their seizures more than anything else, but they were able to improve memory function. They're talking about it for Alzheimer's, but here, as the ethicist, here's what I see happening with this. This is a Neuro Enhancement implantation. What do we say, based upon the previous slide, what about non-demented subjects? People who don't have Alzheimer's, people who don't have epilepsy. You, me, we just want to be smarter. We just want to remember more. And I'm not kidding. It's actually a big deal. There's so much that's out there that's going on, and there's a lot of controversy in the neuroethical world about people taking memory and performance, essentially performance enhancement type drugs to get through college, to pass the SAT. Some of it's amphetamine, some of it's other things, but there's a lot of controversy, and is everybody playing on an even playing field? And wealthy kids who have access to these medications and drugs do better than less wealthy kids who don't, and they've looked at this, and it's very controversial. What happens if we're talking about sticking these things in people's brains? And do you, you or me, who has no pathology going on, but we just want to be smarter, do I have the right to walk into a neurosurgeon's office and say, give me one of those? Interesting. And if you have one of those, how do we level the playing field for somebody who doesn't have access to that or doesn't want to take that risk? It's a really interesting thing to think about, and it is most definitely something that we're going to have to address as a society, something we're going to have to address as healthcare practitioners, particularly in the neurologic field, because the technology is moving in that direction so quickly. So I want you to think about that, because it's really, really, really interesting. And I'm not sure we know what the answer is. And I'm not sure, even if we know society says, oh, this is acceptable or not, if truly it is what we should be doing. And I'm going to be the one they ask to do it. So I think it's an exciting and interesting place to go. And I'm going to leave you with this, because the other things that I haven't talked about are persistent vegetative state. I had a meeting yesterday with somebody who programmed, there were 3 patients in a minimally conscious state deep brain stimulation study. One of the 3 had excellent results. What do I mean by excellent? Well, he was minimally conscious, they stimulated his brain, and he actually was able to ask for Orange Crush. That's what he wanted. You guys remember that stuff, right? But to take somebody who could barely interact with his environment and get him to actually say, I want Orange Crush, that's pretty interesting. And it brings up all kinds of other ethical implications about these persistent vegetative states and where we are and those types of things. So there are all kinds of other targets that I didn't even have time to talk about. And that's why I find functional neurosurgery in particular so exciting. So I'm going to leave you with this thought and open it up to questions. And to quote some very wise folks from the 80s, if you remember that. All right, well, thank you.